ointment. We call it Refresh PM or lacquer loop. Or you could just prescribe erythromycin ointment for the eye. Not for the erythromycin really at all. It's a really weak antibiotic, at least in that ointment form. You're not really treating any sort of bacterial infection. You're mostly using it for the ointment part. The ointment stays on your eyes for a long, long time. We do it at night though because it really gunks up your vision and it's hard to see through, like putting Vaseline on your eyes basically. We can tape eyes shut at bedtime. Patients don't like this, especially if they're prone to nightmares and they can't open their eyes at night. They'll really freak themselves out. We can put temporary sutures in the lateral canthus area, called a tarsorrhaphy. Okay, if you've ever seen a patient with a tarsorrhaphy, they look noticeable. But the tarsorrhaphy works pretty well. Most of the time that's just temporary. And then we can also insert gold weights into the upper eyelid. Gold is inert, so it doesn't react with the body. And that gold weight is supposed to bring the upper lid down. I've seen one patient with a gold weight inserted into her upper lid, and it did not work very well. I think she just probably ended up having a pretty expensive upper eyelid. This is a picture of Bell's palsy. You can see this patient does not, this is probably closer to end stage on the Bell's palsy in the recovery. Again, my student could not do anything with her eye. Like the one eye was closed, the other was wide open. I could mechanically force the eye shut, but she could not do it at all. She had no innervation to her orbicularis oculi or any of the other muscles on her face on that one side. Okay, we talked about ptosis already. You guys know about that. You even know how to pronounce it, which is awesome. Ptosis is a drooping of the upper eyelid. Okay. Sometimes this is much ado about nothing. We don't worry about ptosis until it becomes really visually significant. Unless it's like an acute ptosis, if you got a third nerve palsy and you woke up one morning and your eye's down and out and your lid's not opening at all, we're definitely concerned about that. But a regular ptosis, especially if you just get one from getting older and that lid just sort of starts to droop, we won't do too much about that until it starts to obstruct the superior visual field. Okay, so you can see on this patient here, if you look through the eyelashes, you can kind of see the iris behind it, and then you can kind of see the pupil in the center of that. But the upper portion of that pupil is already being covered by that patient's lid, and that is difficult to see through. Okay, when you close your eyes, it's hard to see anything. And if your eyes closed over your pupil, it's really hard to see anything. So this patient probably still wants to do things like drive. It's not safe for this patient to drive because they're missing their superior visual field. And so we'll do blepharoplasty on these patients oftentimes to correct it. How do you get a ptosis? Many ways. You can just get old. That's how they're most commonly caused. Things sag as you get older. We talked about third nerve palsy. We'll talk about Horner syndrome a little later on. That is a sympathetic nervous system component. So ptosis, meiosis, facial anhidrosis with Horner syndrome. And then myasthenia gravis, as you, we'll talk about that as well. That's muscle weakness. Myo is muscle, myasthenia gravis is muscle weakness. Typically, these patients have muscle weakness that worsens throughout the day, and they won't be able to keep their eyes open because that levator gets tired. Okay, how do we treat it? Typically with surgery. Congenital ptosis here, we're going to want to treat that. Why? What are we trying to prevent? Amblyopia, very good. More congenital ptosis. Okay, now we're on to blepharitis. All right, bleph, eyelids, and lash margins, lid margins. Okay, itis is inflammation. Okay, does that look clean? It's not. Okay. That's why I told you to practice good eyelid hygiene when you come to my lab. So I am not looking at this under my microscope. I have a teaching tube as well that you guys will look through, and then you guys will look at each other's eyes. So if you don't want your peers to think you're gross. Make sure you wash your eyelids that day and every day. You should practice good eyelid hygiene on a normal basis. It's wise. There are certain things that cause blepharitis. If you're more prone to dandruff, if you've got flaky skin, that can cause blepharitis. There's also just a lot of staph bacteria naturally on your eyes, and if you get an overgrowth of that staph bacteria and overcolonization of that, they will start to fester around your lash margins, causing a bunch of crustiness. There's also a mite called a Demodex mite that is microscopic. It will burrow its way into your eyelashes, and it'll eat your tissue and get nice and full, and then it will excrete its excrement around your lash margin, and the little bases of crud that are coming out of the lash margin here are that excrement. Okay, kind of gross. Tea tree oil is what we use to treat Demodex. That will kill the mites and prevent them from defecating on your eyelashes. Okay, signs of blepharitis. Usually you're going to have like the crustiness, the scaliness, flaky kind of grossness. You may be more prone to styes if you have blepharitis as well. Meibomian gland dysfunction. Okay, again, some of the causes: dandruff, staph infection, meibomian gland dysfunction, Demodex. Those are those mites. How do we treat it? Typically, it's when you're in the shower, you're just going to scrub around on your eyelids. Close your eyes first. Okay. And then you can take either some baby shampoo or actual lid scrubs and just sort of massage around on the eyes and debride some of that gunk off of there. Warm compresses are phenomenal. Warm compress is not a hot washcloth. Okay? That's what almost everybody uses for a warm compress. That works for about 5 seconds, and then it's not warm enough anymore, and then you've just got a cold, damp rag on your eyes, and that's not good for your skin. You'll get really wrinkly that way. Instead, what you should do is either on Amazon you can buy a Brooder mask that is a dry, warm compress specifically for blepharitis and meibomian gland dysfunction. You take this mask and you throw it in the microwave for about 20 seconds. And then you put it on your face and you wear it for about 10 minutes. That will warm up the meibomian glands, and you can kind of milk your meibomian glands this way, secrete some of that oil out of them. That will refire them and get them working more properly the longer you use it. If you don't want to buy one, you can make your own dry warm compress. You can take a clean sock and some uncooked rice and make a rice pack basically, tie the sock off, put that in the microwave, and then put that on your eyes as well. That works quite well if you don't want to buy a Brooder mask. But the Brooder masks, they're great. Highly recommend. It's like a spa for your eyes. I wish I was getting paid by them. I am not. Severe blepharitis, you can use antibiotic therapy. You can use erythromycin ointment. It's probably not going to do much at all for the patients, quite honestly. You could do Doxy as well. Doxy is not necessarily for the antibiotic capabilities or qualities of the drug, but more for the anti-inflammatory properties, disrupting the MMP9s, tallow matrix proteins, I think is what that stands for. I'm not a big Doxy fan either. Typically, I don't prescribe medications for patients with blepharitis. I will just have them get cleaner. Hygiene is the best way to do it. Okay. 4 pictures of blepharitis. These patients are starting to get their lashes matted together. That's kind of like clear mascara there. You don't want that. The patient in the upper left picture there looks like they're starting to lose some lashes as well. That's not good. And also, this is a good picture of what the meibomian glands look like. So those little dots on the eyelid margin there are the meibomian glands. All of these glands are capped. They look like little pimples. Okay, I go crazy big Dr. Pimple Popper fan, and I can be my own Dr. Pimple Popper when you come into my office, and I'll pop those little things and just watch them. It's awesome. Really fun. Probably do that to some of you guys when you come into the clinic as well. This is chronic blepharitis. Don't let your eyes get like this. I don't know why people let their eyes or skin or anything get this bad. That patient's not going to have a good outcome. This is a picture of those Demodex mites. Okay, again, they burrow in at the base of the follicle there, and they will go head first. So, yeah. Okay, moving on. We have a hordeolum. Underline the H in hordeolum, and right next to it, hordeolums hurt. Hordeolums hurt. Okay. These are acute, painful nodules on the eyelid. So if you've got a painful bump, if you have a patient coming in, say, I have a bump on my eye that just appeared, and it hurts. It's a hordeolum. Okay? Pretty much stop right there. Not really much to diagnose. You already know what it is. It's a hordeolum. Painful bump on the lid. Again, there's a lot of staph bacteria around the eye. Sometimes that staph bacteria can climb its way into the meibomian glands and then get capped off in there and grow and fester, and that causes a hordeolum. How do we treat hordeolums? I'm pretty aggressive with hordeolums. So if a patient comes into my clinic and they have a larger hordeolum, and I don't see a distinct head on it that I can pop and get all that gunk out of there, I'm just going to put them on an oral antibiotic. It's inside of the eyelid at that point. So it's not on top anymore, it's actually inside. So topical medications are going to be of no use to you. You have to use an oral medication if you're going to treat a hordeolum that's really painful and large. If it is just a smaller one and it doesn't hurt quite as bad, and you can see a little head on it, you can use the dry worm compresses to try and warm that up and then try to pop it out. And then perhaps use a topical erythromycin ointment if you see the head. If there's no head and it's just a bump on the eyelid, which most of them are going to be presenting like that, then just put them on oral Augmentin is typically what I'll use. You can use Doxy. I like Augmentin. Okay, that's going to need an oral antibiotic. That one's pretty big. This one's not quite as big, but I don't see a head either, so I'm going to give that an oral antibiotic as well. Okay, chalazion. Chalazions are also bumps on the lid, but chalazions do not hurt, so they're painless bumps on the lid. Chalazion, you can underline the CH in chalazion and underline the CH in chronic. Chalazions are chronic. Okay, so a few things can happen if you get a hordeolum. Again, hordeolums hurt, painful acute bump on the lid. Hordeolums can self-limit on their own. Okay, your body's immune system can fight off the infection and they can cure themselves. We can also treat the hordeolums with the antibiotics or the warm compresses. And hopefully they go away. Hordeolums can maybe not be treated and then perhaps fester into a larger infection of the entire lid called preseptal cellulitis, which is a bad thing. We'll talk about that a little later on. Or they can sort of calcify. So your body's immune system has done a lot of work but didn't quite get all of the gunk out of there. And that gunk is going to end up calcifying in the lid. And that calcific mass is going to be what we call a chalazion. So they're hard, painless bumps in the eyelid. Okay? We don't necessarily need to do anything about them unless the patient is worried about the cosmesis of the bump. But chalazions, they're chronic, they're painless, they're large, not necessarily large, they're firm bumps on the lid. Okay, you're going to have patients probably coming into your office complaining of chalazion. The way that the DHA wants you to manage these, which is kind of silly because warm compresses and lid massage is not going to do anything for them. But they have to do that for 3 to 4 weeks, and then you can refer them over to ophthalmology, where ophthalmology will either inject it with a steroid, a triamcinolone injection, or do what's called incision and curettage. So they'll just make a little incision on the chalazion and take like a tiny little ice cream scooper and get all the gunk out. Again, if you watch Dr. Pimple Popper, you've seen incision and curettage on non-lid things. Any Dr. Pimple Popper fans in here? Good people. Okay, another picture of a chalazion. Patient's not in any pain. We don't have to treat chalazion. If they don't want to get it surgically excised, they can just live with that bump forever. It's fine. Most people don't like the way it looks though, so they want to get it treated. Another picture of chalazion. How do we know that's a chalazion and not a hordeolum? Yeah, but if you're just looking at this picture, you probably wouldn't be able to tell. So you're going to have to ask the patient questions. You know that it's a chalazion because it says chalazion at the top of this slide. But yeah, you would have to ask the patient like what their symptoms are. Okay, good work. Okay, this is a video of a chalazion removal. Another picture of a chalazion. All right, now we're moving into the dacryocystitis, the lacrimal system disorders. So dacryo means lacrimal. Dacryo means lacrimal. Itis is an inflammation or infection. And cyst means sac. Okay, so knowing that, dacryocystitis is an inflammation of the lacrimal sac. And we said the lacrimal sac, covered this yesterday, the lacrimal sac is located inferior nasally, kind of by the nose. If you see a large bump and the patient's in pain down in the lower nose area, they potentially have dacryocystitis. So they're going to have potentially some discharge, some pain, a lot of swelling, okay? Potentially preseptal cellulitis, which is like a lid infection as well. And oftentimes these are caused by a bacterial infection. Again, there's a ton of staph bacteria on your eye. If that staph crawls down your punctum, your tear duct, through the little canal in there, the canaliculus, into the lacrimal sac, and then grows and festers there, you'll get dacryocystitis. How do we treat it? It's not topical, okay? It's not on top. This is inside the body. You got to use an oral systemic medication. Okay? Augmentin or Keflex are probably the two drugs of choices there. Okay? Strong antibiotics. We want to clear this up right away. Warm compresses, perhaps, maybe, but typically it's just the oral antibiotics are going to take care of this. If you see this, you can put them on an oral antibiotic right away, but then I would punt them over to optometry or ophthalmology for more follow-up care. Okay, that's dacryocystitis. Please don't confuse that with dacryoadenitis. Okay, once again, dacryo means lacrimal, itis is inflammation, and here we have adin in the middle. Adin means gland. So this is an inflammation of the lacrimal gland. Once again, the lacrimal gland is located sort of superior temporal on the side of your face. Okay, so you've got swelling up there, pain, maybe some tearing. Perhaps that patient has a dacryoadenitis. Okay, sometimes these are caused idiopathically, sometimes it's an autoimmune response, sometimes it's a bacterial infection. Okay, we don't really know necessarily what is causing it, we just know that the patient has a dacryoadenitis. So we got to figure out, number one, what is causing it. So you got to do kind of an extensive workup, figure out if they have any autoimmune conditions, maybe do a CT scan, maybe biopsy that gland. Or if there's any signs of bacterial or viral infection. And then to treat it, typically we just start with oral antibiotics anyway, because if it is a bacterial infection, we don't want it to continue to fester, so we're just going to throw them on a oral antibiotic. Sometimes if the antibiotic's not working, we'll put them on a steroid. If it, then we're suspecting it's an inflammatory cause. A lot of times we're going to start with systemic antibiotics to see if that works. It's called practicing medicine, not Okay. This patient has kind of a swollen upper temporal lid area. Could be a chalazion, could be dacryoadenitis. What would differentiate it from a chalazion? Pain, yeah. So pain would be more indicative of a dacryoadenitis. All right, then we have dacryostenosis. Dacrostenosis, also known as a nasolacrimal duct obstruction. Okay. So this is a blocked tear duct, and oftentimes we'll find this in infants. This is actually pretty common in infants under the age of 1 year old. Okay. So when they're growing, infants, the nasolacrimal duct is one of the last things to form fully. It's oftentimes just closed, especially in preemies. It'll be closed, and there's no place then for the tears to go, so they're just going to run down the side of their face. Parents are going to say, "Why is my baby crying all the time?" And you say, "I don't know. I'm sure it's not you. It may be that their nasolacrimal duct is obstructed." Okay. The good news is that almost all of these infantile nasolacrimal duct obstructions will resolve spontaneously. So that duct will just open up. As the infant continues to grow, that duct will finally open up, and then they'll stop tearing down the side of their face and tear like normal. Then if they're tearing down the side of the face, then it probably is the parents, and it wasn't the nasolacrimal duct. All right, we'll talk about keratoconjunctivitis sicca. Okay, this is another fancy name for dry eye. Okay, we already talked quite a bit about the tear film. It's got 3 layers: the oily outer layer, the middle aqueous watery layer secreted by your lacrimal gland, and that inner mucus layer. That's what keeps the tears on the eye. Okay, and I've already talked about the Bruder mask. There's what it looks like on the bottom there, and then the eye drops as well. We can use one other technique in the optometry clinic. It's called a scleral contact lens. This is a hard contact that actually it's quite large. It fits all the way over the cornea, and it rests on the sclera itself. And it's not your soft, normal contact lens, it's hard. And we actually fill the bowl of the contact lens with a saline solution, and then put that on the patient's eye. And then their eye, the cornea itself, is always being moisturized by that saline in there. So for severe dry eye patients, we'll use a scleral contact lens quite often. And optometry is the one that will prescribe that. That's one of the few things that we do that ophthalmology does not. That and giving you glasses prescriptions. They're not great at that. Let's take a 10-minute break.
You don't got no Wi-Fi?
That just means I have more time to study.
More time.
I have to study more.
Oh, this one. Where is she?
Where's the channel day?
In Denver.
It's like the opposite.
Round trip was 300, but that's also across 2 different airlines because I had to do Southwest there and then Frontier back. Yeah. But here's the big but is it was only more expensive because of the timing. Because if I flew her out on Wednesday, it would have been like 186. But because she works Wednesday, her interview's Friday, the the 2 days for flying out, the only 2 days that she could do were the most expensive days. So like, that's how it goes. But like if she wasn't working, then I could have gotten flew her in earlier and it would have been way cheaper. If you're going back, I would just like look at the flights.
Yeah, there's like trash. Like,
Because Frontier runs goes to Miami International, and they have cheap flights. And I always use Frontier Spirit just because you get free baggage when you're there anyway. So, like, you don't have to worry about baggage. So, like, yeah, the planes are cheaper because it's cheap. I prefer Frontier. And then if that doesn't always work, you can do Fort Lauderdale. I've flown in and out of Fort Lauderdale a lot. Just because Spirit that goes to Fort Lauderdale, so that I can get flights in there. But yeah, Frontier's like, you should just go on Frontier's website and see what dates it's always like every day of flights.
I know that's what I was thinking.
Yeah, like if you want to see even on Friday, they have flights or things like, what am I doing? Oh, Veterans Day? Yeah, November. Yeah. Yeah, they're all stupid.
Late at night, but it was like 13 hours.
Yeah, it's because of stupid layovers.
Sir, did you do your research on the?
Yeah, I don't think I could not find any glasses.
So I wore them last night, and I was like just trying to like. I really think, sir, it's just more of the light itself limiting.
Once I saw, I did see. I did find one pair.
You're leaving that
16 bucks.
Wherever the day is,
It's gonna be Friday. So that morning.
so say Monday and Tuesday.
Yeah. Because the actual day is on Tuesday.
Yeah. But mine are definitely like when I put them on, the white light turns more yellow.
Yeah.
So yeah, which I said for $15, even if it doesn't do, I always say like,
Are you flying back on the last day?
but
Would you want to do that?
yeah, I guess
Okay.
Wherever the.
So yeah,
it
you're
does.
on that
Like
Tuesday.
I said, you don't work.
Wait, so you leave that Friday and come back that Monday. That's what they have available. Yeah, they never have
It's just at night, so it's not like
it's always like early morning.
but like we do like stuff like that in private home.
Like
It's like to the point where if I'm not wearing something,
this is round trip for $146.
Oh, what time?
and it's the newer lights that really bright.
Yeah, so
I had glasses, so it's like I said, I was like the 6 by the time I got LASIK, so it was pretty bad. But like the old lights, like these cars used to have were the yellow lights, and they weren't the blue white light. So they were terrible when I first got my license. And then if you have a lifted truck and it's like white, I definitely use my mirror, like flip the mirror and all that stuff. Yeah.
they don't need.
Yeah, I'm kind of interested now, like this angle, because I mean, I've had LASIK my whole life, even before LASIK, so it's like, I wonder if, like, I've never looked at the numbers, I just knew the prescription, I have noticed that there was numbers obviously after, and I never knew what they were, I just like the first 5.75, but,
You want to just spend
yeah,
Friday
for $15, it's really not. I mean, I almost did buy the colorblind ones too, which those were expensive. They're like, you can see like $400 or $500, yeah. And I'm like, well,
Come on, dude. Come on.
making Quizlets?
Yeah, that's what I do. So I make my how I study is like I just make Quizlets during the lectures, and then I study all my Quizlets, and then I use when they make all the Gemini tests, and I use like those and something on, and I just kind of go back and forth. I normally don't use the actual slide for radiology, because you kind of have to use it for radiology, and then what I do is I'll do the Quizlets and the test up until test day, and the morning of test day, I go through all the slides as like a last minute thing before the test. That's my strategy. It's worked so
I
far.
like that. As you doing the copy and paste. It's not
I
bad.
upload. So basically, what I do is I upload it into it,
Yeah.
and then I just fix what's wrong. It doesn't get it right most of the time. Like when I upload it, that's how I want it to be. So I'm just fixing what's right, and then also listening to see it and seeing it.
Oh, so you just take the entire PowerPoint. It separates it all.
Yep, it'll make flashcards out of it.
Oh, that's awesome.
So then I formulate how I want to formulate it, and then I study the best of questions, so I kind of like make it so it's like questions with the Quizlet, maybe have like the plus or whatever. You can use like a test or learn function, and it makes like multiple questions for you. It's $30 a year. So that's like, because like I remember I was just I like it. It's like $5. So then I use Quizlet in the past, so I just got the because like you can use all the free ones, just get enough. So I bought the $35 for the whole year.
I like that. I thought you were doing
Trying to smooth the future.
That would be phenomenal.
So like,
Yeah.
I can show you like, and the only issue with it is like you kind of have to think like how what I'm doing to get it to like, yeah. I had a change time organizer from freshman to now because freshman year I just had it was like my library. Library and showed you all my folders. Like I had in
This would be so helpful because I too use a lot of the places that people use. I mean, I'll go through the slides once, and usually just look and do what you I'll take notes and what I do.
yeah.
But people have stuff going on. And I probably could do it myself.
It's absolutely yeah, like I'm just like absolutely good.
Yeah.
So like last semester I had like a folder for each classes, right? And then I was all like I wanted to separate freshmen from sophomore, and there was no way to like separate it like release it on one folder. So what I learned I can do is I just made like an iPad software folder, and then you can just make tags. So basically I made each class a tag, so I can pick the class, all my farms, all my radiology, HFT, and lab, cycle started. So
I'll take out a lunch.
So like
That's so helpful.
yeah, so you do a radiology, right? Chest lecture.
There's a thing like
You have like multiple flashcards, and you can say like you want to do a flashcard. I did that for some last semester, and I was like, this is beneficial. You have all these games. I used to remember using it.
I think I've worn mine twice at home.
Takes the flashcard. Right?
So I did ask him. He said like if you are
It didn't
staring
make
at a
that
screen,
super fun.
it
I
doesn't
think the
help
system's
with
on
processing.
it.
It also when it's straight
and start making it.
like staring at the screen so much.
Yeah, it's like in order.
It has nothing to do with
combination. So plain text radiology, and then you give multiple choice. The actual, the last part answer, like the actual answer. Sometimes it's like it'll make like false answers, or just use answers from other flashcards. So then it's like okay, this one. cool, right? And then you go to the next one, and then you can shuffle. So like once I go through it multiple times and I kind of know it, then I'll bring the shuffle. It can give you written questions, select out all five. I can go through first.
Yeah.
If you want to answer with a term, with a definition.
I like spelling it out.
Yeah, it's like how you work the best. And then if you don't want to look at the one by one, you can do the test option here. You can just do a test out of all of
I've done
them.
that before. Yeah. Raise like some multiple choice, some
So I'll tell you what I do. So like when I make it from the class, and then like when I start actually studying the class, I'll do it. And then once
Alright, we'll get started back up here.
all the Gemini tests or whatever.
It sounds like there's a moderate amount of confusion with Florias and Tropias. That's fair to say. Just the one that came in. I'm gonna probably say there probably is some confusion between that, and that's fair, because it's not a simple subject. So when you guys come to the lab, we'll demonstrate both cover tests. I don't know if you guys are getting taught properly how to do the cover test either. We'll teach you the proper way to do it. And again, that's something that I'm working on changing with the way that you guys get taught the eyeball. But we will teach you the proper way to do cover tests, and hopefully that will make a little bit more sense with Florias and Tropias. And I've got other docs and some of my texts that can explain things better than what I do as well. So if it doesn't make sense with me, don't worry about it. It'll probably make sense with my counterparts who are smarter than I am. So more to follow when we do the lab. All right, let's segue very awkwardly onto cancer. Cancers of the eyelid. Okay, I want to just talk about a couple of them. Not really so that you worry, just so that you just pay attention to your patients. Okay, because oftentimes they're going to come in with weird growths on their face, and they're going to look normal to them, but they're not normal, and you're going to be able to tell that they're not normal. So we'll talk first about basal and squamous cell carcinoma. Basal cell is the most common form of skin cancer. Squamous cell is the second most common. They're pretty common around the eyeball itself, especially in older sun worshippers. Okay. My parents live in Sun City West Retirement Community in Phoenix, and there's a lot of basal cell cancer down there. A lot of leathery skin. They have nice tans though. Again, most of the time with these, they're symptom-free, so they're not painful really, but they're just there, and they don't get them removed until it's too late typically. So basal cell, most common malignancy, elderly, fair-skinned folks, lots of sunlight. Okay. There's multiple types of basal cell carcinomas. Nodular, nodulo-ulcerative, and sclerosing. Got some pictures. This would be nodulo-ulcerative here. Nodular. And I don't have a picture of the other one. Squamous cell, less common. It's the second most common. Squamous S is second most common. More aggressive though. Not a hugely bad outcome. If you have basal or squamous cell carcinoma, typically they can get these removed with a oncologist or a dermatologist. Multiple types here as well. There's nodular. Here's an ulcerating squamous cell carcinoma. Okay. That, I believe, is an upper eyelid. You can kind of see like the lid margin would be like right here, some lashes right there. This is probably like the medial canthus, lateral canthus. So this patient probably just can't open their eye very well because they've got a big old piece of cancer on there. Don't let it get that bad. That didn't just pop up yesterday. That's been there for a while. Some miscellaneous lid conditions. A lot of these have to do with lid malpositions or eyelash issues. Trichiasis is multiple rows of eyelashes. Okay, ladies up there, you might think that's awesome. I've got real thick lashes. It's not, because they get real oddly grown, and then they'll typically have to get epilated or plucked because they're rubbing up against your cornea. You can have floppy eyelid syndrome. It's just the funniest name, but it's really what it is. The eyeball just, or the lid just sort of flops all over the place. Molluscum contagiosum, common in kids. This is a viral infection that can happen not just on the eyes but around the body. But you can get lid lesions with molluscum. Blepharospasm is a hemifacial spasm. Okay, so if you have a lid twitch, which I'm sure a lot of you, especially in IPAP, will get lid twitches because you love caffeine, you hate sleep, and you love looking at things up close. Your lid can twitch every now and then. That is called faciomyokymia. Okay, that's a lid twitch. Blepharospasm is actually the whole facial nerve on one side spasming and freaking out. They'll give Botox for blepharospasm, not just typically for a lid twitch. By the way, if you want to cure your lid twitch, don't drink caffeine, get more sleep, and don't look at things up close. And then you fail out of IPAP. So probably just embrace your lid twitch while you have it, and eventually it'll go away. Herpes, not hispies, herpes. Herpes simplex and zoster can cause issues on the face, lid lesions. Okay, with simplex, there are two types. Okay, when I was a fourth year extern, I had a patient with a herpetic lesion on his cornea. He got real freaked out. He's like, man, I got herpes. I was like, there are two types. You have the above the belt type. I don't know if you have the below the belt type, but I'm not testing for that because I'm an eye person. So two types. Cold sores, herpes simplex type 1 can affect the cornea and the trigeminal nerve. Type 2 is that below the belt. Zoster or shingles can be very painful and affect the eye, the lid, the skin, and the cornea as well. And we'll talk in a future lecture about preseptal and orbital cellulitis. Here's a picture of trichiasis. Those lashes are growing crazy. Floppy eyelid syndrome. That thing is flopping. Zoster. Check it out how Zoster is pretty cool. Well, no, it's not. Zoster is interesting. It's not good to have, but how it really just affects the midline. It's interesting about it. Not cool. Zoster in a kid. I've got a funny story about Jordan Graff that I'll tell you guys when I'm not behind. I got yelled at by Jordan Graff one time. Not fun. All right, last lecture here. Conj disorders. Okay, we've got conjunctivitis. You guys are going to be seeing conjunctivitis quite a bit. Viral, bacterial, and allergic conjunctivitis is what we're going to talk about, and I'm hoping that you can differentiate between the three, and I'm also hoping that you learn how to treat conjunctivitis so that I don't have to treat conjunctivitis because it's very contagious and I don't like to in my office all the time. Okay, anatomical review here. We've got the palpebral conj is the inner lining of the lid, and the bulbar conj is the outer lining of the eyeball itself. And where those two conges come to meet is called the fornix, F-O-R-N-I-X. I talked about that yesterday. I don't think it was on the slides, but here it is. The fornix, the spot where the bulbar and palpebral conj meet. Okay. More pictures there. You can see the limbus as well, bulbar conj. Again, the limbus is where the white part of the eye meets the cornea. All right, viral conjunctivitis. This is pink eye. Pink eye. Viral conjunctivitis. Most conjunctivitis is viral conjunctivitis. Okay? So symptoms for these patients, they're going to know something's wrong. Their eye's not going to feel quite right. Who's had viral conjunctivitis in here? Oh yeah, pink eye. You know something's wrong, right? Your eye doesn't feel right. It's going to be having a little bit of a discharge. Typically that discharge is a watery discharge, And you may have a little bit of discomfort in that eye as well. It's also going to look red and or pink and irritated. Okay, pink eye. All right. Signs that you're going to see on these patients: a watery discharge. We call it a serous discharge. Okay, so it's watery in nature, but that water has a bunch of protein particles in it. So some of these patients will wake up and their eyelids will be crusted shut. Okay, and that crustiness comes from that watery discharge and the protein particles that get stuck on the lashes themselves, and that's what kind of glues those lids shut. Eventually, they're able to open them, and they'll debride some of that gunk off. Hopefully, otherwise that's really gross. You can have what's called preauricular lymphadenopathy. Preauricular, in front of your auricles, your ears, you've got some lymph nodes, and they may get a little bit swollen or tender. A lot of times these patients will have had a viral infection, an upper respiratory infection, and they'll cough or sneeze and wipe some of that snot on their hand, and their eye will itch, and now they've infected their eye. Okay. The other ways that you can get pink eye are somebody has pink eye, they wipe their eye, don't wash their hands, and they touch a doorknob, right? And then everybody that touches that doorknob and then wipes their eyes also has pink eye. There's a rumor, I don't know if it's true, probably doesn't do any good to your eyes, but if you fart in a pillow, like, that'll give you pink eye. I don't know if you've heard that. That should be something that I talked about when I was a kid. You probably could get pink eye that way, I suppose. Maybe other infections as well. I don't know. Don't fart in pillows.
Damn.
In AIT land, especially here, the students don't have great hygiene because they're young and pretty young. Good kids. They will have pink eye. We have to quarantine entire barracks sometimes because they just spread pink eye all over the place. We've had literally hundreds of patients with pink eye in the walk-in clinic at the TMC. That's not fun. That's a busy day for us. The last bullet about chlamydia is interesting there. Chlamydia looks a lot like and presents a lot like viral conjunctivitis. I had a patient come in to the TMC with what I diagnosed as viral conjunctivitis. He had a watery discharge, kind of redness on the eye. His AIT, so I was like, yeah, it's probably pink eye, man. Sorry, you're probably going to get it in the other eye because oftentimes that'll happen. You get the pink eye in the one eye, and then you wipe your tear, and then you touch your hands, and then you wipe your other eye, and now you've infected both eyes. So oftentimes it's in both eyes. Typically, as you'll see, it will resolve on its own within a week or two. So I always tell patients, come back in 2 weeks if it's not better. He came back, and I was surprised. And it was actually worse. It's like, oh, this is probably not viral conjunctivitis. And then me, being who I am, I phoned a friend, because I do that often. And they're like, did you consider chlamydia? And I was like, no, I did not, but I will now. Ran a chlamydia screen, and he had chlamydia in the eyes. And how do you get that? Same way, typically by hand hygiene. Okay, go to the bathroom and don't wash your hands, and then you touch your face. You get chlamydia. You can also get gonorrhea in the eye. That's really gross. I'll show you pictures of that later. This is a picture of a swollen preauricular node. Okay. So viral conjunctivitis, as I said, is self-limiting. Your body's own immune system is going to take over. We don't really prescribe anything for patients with viral conjunctivitis because it's better to just not touch that eye. If they do have to touch the eye, if they have to put in some artificial tears or something, we tell them to wash their hands copiously before they touch the eye, and then wash their hands copiously after they touch the eye. It's all about hand washing, hand washing, hand washing. And stop touching your eyes. Okay. We really don't prescribe topical antibiotics for viral conjunctivitis for obvious reasons. It's not a bacterial infection. If there's a concern about a secondary bacterial infection, like if the viral conjunctivitis is really bad and it's eating a hole into the cornea, perhaps we'll put a bacteria or an antibacterial on there to prevent a bacterial infection. But most of the time, probably 99% of the time, it'll just limit itself on its own, and they'll be back to normal in a couple weeks. It is very contagious. You You have to wipe everything down in your office with Cavicide, and that gets old after a while. All right. Pictures of viral conjunctivitis here. You can see some kind of gunk on the eyes there. The palpebral conge is red, injected, kind of got some bumps on it as well. That's serous discharge. Sometimes you can have, it's called like a pseudomembrane. That would be the picture in the bottom right there. You can have little infiltrates in the cornea. These are just clusters of white blood cells in the cornea. Okay. But it'll resolve on its own typically. That's viral conjunctivitis. Watery discharge, both eyes, starts in one, moves over to the other, and it's self-limiting. Wash your hands. Bacterial conjunctivitis is much more noticeable. Okay? This is a bacterial infection, and it's going to have an obvious discharge to it. Okay? This is less common than viral conjunctivitis, still kind of common. These would be the bacterial causes listed here: staph, strep, Haemophilus, and then there's some STDs that can also cause it as well. Okay, it's not a pink eye with bacterial conjunctivitis. We describe it more of a beefy red eye with irritation, and most importantly, a mucopurulent discharge. Mucopurulent discharge. This is one of two places you'll see the word mucopurulent discharge. The other was with, you guys remember? I talked about it already. Dacryocystitis has a mucopurulent discharge as well. That's the snotty mucus on the eye there. Okay, that shouldn't be there. That is from the bacterial infection. Okay, if they have a mucopurulent discharge, we are going to give them antibiotics, right? So topical antibiotics are the drug of choice here. Why topical? Because you can put the medication right on the thing that's infected. Okay, the conge is right on top of the eye, so you can put a topical antibiotic on there and it works just fine. These are two types of topical antibiotics listed: Vigamox, moxifloxacin, and then Polytrim. Those are probably the two most common antibiotics. You'll notice the cap color on the Vigamox and the little strip on the Polytrim is tan. Most ophthalmic medications are color-coded based on their caps or on the boxes themselves. So tan medications or with a tan cap are going to be antibiotics. So remember them as antibiotics. Okay, bacterial conjunctivitis, again, topical antibiotic. If it's really bad, gonorrhea, perhaps chlamydia, an oral antibiotic, because there's a chlamydial infection or a gonorrheal infection throughout the body. Perhaps then you use like the IM shot or the oral antibiotic. Otherwise, topical antibiotics are typically the drug of choice for these patients. Okay, that is not a happy looking eye, right? There's a lot of gunk going on there. Here's what chlamydia looks like in the eye. Okay, also not a happy eye. Doesn't look quite as beefy red, so you can see, perhaps, maybe you give me the benefit of the doubt how I could have mistaken that as a viral conjunctivitis. Not a lot of discharge with chlamydia. Gonorrhea in the eye is pretty gross. It's hyperacute discharge. If you wipe it away, it's going to be back very quickly. It's really, really not something cool to have. That's a lot of discharge on the eye right there. Obvious bacterial infection. All right, and then we've got allergic conjunctivitis. Okay, allergic, you're thinking allergies. Typically, allergies will affect the entire body, so this is going to be a bilateral condition. And the biggest thing that these patients are going to complain about is itchiness, itchy eyes. Okay? Most of the itch is going to happen nasally as well. Okay? And these will be seasonal especially if you're here in Texas. January to March, pretty awful. And then year-round is also not super enjoyable here in Texas with seasonal allergies. If you got pet dander, especially cats, cats will give you allergies as well. Dogs less so. Dust, plant pollens, ragweed, mold spores, anything that gives you allergies can give you allergic conjunctivitis. Intense itching is going to be the biggest symptom. These patients are going to come in complaining of itchy eyes. They may have a little bit of a discharge as well, but most of the time it's just going to be that itching. Okay. Signs for them, it's going to be bilateral, so both eyes are going to be affected. Maybe some injection, maybe a little bit of swelling of the conj. We call that chemosis. Swelling of the conjunctiva is chemosis. And then some bumps on the eye as well. Those are called papilla. How do we treat it? You can eliminate the inciting agent, but if that's seasonal or a deer pet, you're probably not going to do that. So instead, we'll typically just go ahead and prescribe topical antihistamine drops. Pataday is listed here. I love Pataday. Pataday once daily extra strength is phenomenal. If my eyes ever start itching, I just put 1 drop of that in each eye, and I start the day, and then I'm good to go for the rest of the day. If it's really bad, we'll do a topical steroid. You guys are never going to prescribe topical steroids, okay? I'll say that now, and I'll say it many times throughout the lectures. That will be an option, perhaps, for you when you're taking tests. It's probably the wrong answer. Topical steroids are something that you really shouldn't be prescribing because when you prescribe a topical steroid, sometimes they can affect a patient's intraocular pressure and make it increase, and you guys don't have the ability to check IOPs and monitor it. So just let optometry or ophthalmology do the topical steroids. You guys feel free to prescribe as many topical antihistamines or oral antihistamines as you want, and trust me, you will prescribe a lot of them, probably to everybody that you see. This is a picture of the bumps on the underneath of the eye, the palpebral conj. And that is all for the conjunctivitis. Now we're moving on to a really benign condition, but patients are going to be freaking out when they have it. A subconjunctival hemorrhage, or subconcheme, bleeding underneath the conjunctiva. If you take a look at this picture, the red area right here is blood underneath the conjunctiva. Does anybody else notice anything wrong with this picture, this patient's eye? It is dilated, yeah. He does have a laceration. You know what's really funny? I never noticed that laceration until last class. Somebody pointed it out, and they're like, doesn't he have a lid laceration? Are we looking at the lid laceration? I was like, oh, you know what? He does have a lid laceration. Also a subconcheme, but there is a lid laceration there too. We'll talk about lid lacerations in the trauma lecture. That may be something that you guys deal with downrange in the operational environment. But for now, focus on the bleeding underneath the conjunctiva there, the subconjunctival hemorrhage. You can get these asymptomatically. You can get them if you're on blood thinners, you can get them if you've had trauma, or you can get them if you're constipated and you're doing a Valsalva maneuver trying to work things out. Okay? If you're pushing real hard, or if you're doing a AFT, the Army Fitness Test, which I have tomorrow morning at 3:40. 3:40.
That's silly.
Yeah, I have to be here. Not wake up at 3:40. I have to be here, ready to PT at 3:40 tomorrow morning. Super pumped up.
Real good track.
My Air Force counterparts really enjoy the fact that we have the PT at 3:40 in the morning. They do it at like 9.
Alright, so.
Anyway, wallowing my sorrows later. All right, if you have a patient coming in with subconcheme, they're probably going to be freaking out. They're going to call, they're going to come to your clinic, and they're like, my eye is bleeding, I am really worried. because it's pretty obvious that there's something wrong with their eye. And there is. It's just not really that concerning. Okay? With the subconjunctival hemorrhage, it's basically like a bruise underneath the conj. Okay, a blood vessel got popped, there's bleeding underneath it, that blood's got to go somewhere before it gets resorbed into the body. It usually takes a couple weeks to straighten itself out. You'll have to ask them if they're on any blood thinners, if anything happened. But again, most of the time, it just happens. They'll wake up or they'll get it throughout the day and they'll be like, my eye's bleeding, and they'll really be freaking out. So your job is to, number one, diagnose it, and then number two, kind of provide reassurance that it's just a subconjunctival hemorrhage. It's kind of like a bruise on the eye. You're not in any pain, right? You didn't lose any vision. Eventually that blood will resorb itself into the body, and it'll go away and you'll be back to normal. Do a thorough workup though. If anything doesn't check out, punt these patients over to optometry or ophthalmology. But most of the time, this is a very simple thing to treat because you don't really treat it. It just goes away. Another picture of a subconcheme. Another picture of a subconcheme. I actually took this picture. This is a patient I saw when I was a fourth year extern in optometry school. This guy came into my clinic and he's like, hey, I kind of woke up and my eyes, something's wrong with my eye. I was like, dude, no kidding. That's a massive bleed on your eye. It's so massive that you can see he's got what's called Munson sign. So his lid is actually like protruding down there. The guy was in no pain, just an ordinary rancher from Arizona. Probably did not want to come to the doctor, one of those types, and probably did not come back for any sort of follow-ups. Just let it heal on its own. But that is what a subconjunctival hemorrhage looks like. Okay, moving on to a pinguecula. Pingueculas are really common. Okay, most of you probably have pingueculas. Pingueculas are little, almost like a callus on your conjunctiva, okay? And they happen temporally and nasally, on the temporal and nasal conj. A lot of times they're due to excessive sunlight exposure, or if you're in a dry or dusty environment. So I saw a lot of these when I was in Arizona because it's really dry, really dusty, and there's a lot of sun there. And if you don't wear sunglasses, you will potentially get pingueculas. They don't really do anything. They just kind of sit on the eye. They're not really bothersome or troublesome. So typically we just let them alone, and patients are just fine with them. But if you see a patient and they have a yellow spot, or if you guys are looking under a slit lamp and you see something temporally or nasally under the slit lamp, it looks like a little yellow raised mass on the eye, it's probably a pinguecula. They're quite common. Okay. Sometimes they'll be irritated. Sometimes they can cause excess tearing or burning. Oftentimes the patients are very asymptomatic about them. Really, we'll just prescribe artificial tears if they need something prescribed to them, and we'll recommend that they wear sunglasses outside. And these are pictures of pingueculas, right? You can see those little raised lesions on the nasal and temporal conj there. Lubricate, and if they do become painful or inflamed, that's when optometry or ophthalmology take over with topical steroids. Okay, next we'll talk about a flick tenule. This is a staph hypersensitivity. These are not super common. I've never seen one. Not to say that that means a whole heck of a lot, because many other docs have seen them. But it's going to be just a focal area of white blood cells collecting at the limbus right there. So that is a flick tenule. Hypersensitivity reaction to your bacteria. Your body does not like all the staph around your eye, and it's going to send a bunch of white blood cells there. Then we got a nevus. These are benign. We don't worry about nevi until they turn into melanomas. We don't like melanomas. We don't mind nevus, though. You can biopsy them, but they're pretty common in a lot of folks. You can have them on the conj, you can have them on the lid, really anywhere. And unless there's a feeder vessel or any other abnormal growth to them, we just let them alone. And these are nevi. They're pretty big, but they're, again, just a benign, non-cancerous growth. They're slow progressing. Maybe they grew one day or they grow really slowly over the years, but they're not rapidly growing like a melanoma. Another picture of a nevus. Now we've got some melanomas. Okay, you notice on these, number one, they're going to be faster progressing, so the patients may notice that they've got a change on their eye, and then we've got those central feeder vessels, those blood vessels coming to the melanoma as well. That is very indicative of a melanoma. These patients, if it's early enough, they may be able to save the eye. Otherwise, if you have a melanoma like this, you're probably going to lose your eyeball. Hard to see when you don't have one of those. More pictures of melanoma here. Okay. Now we're moving on to conj lacerations. Okay. So you saw a lid laceration on that subconjunctival hemorrhage picture. We're talking about conj lacerations now. Now these are more common in the operational environment. Okay, and we may see these if you're downrange, especially with the increased incidence of drone strikes. There's a lot more head and neck trauma going on in modern warfare. So be prepared to fix a conj laceration. It's just the conj that's lacerated though in this case. So most of the time if it's just a conj laceration, the globe is still intact, which is good. It's definitely a concern if you have a ruptured globe. Hopefully you don't. If it's just the conj, it's not all that bad. What you can do for these patients is try to just put a Fox shield over them and then get them over to have a CT done to rule out any sort of open globe. Okay, you can treat these and they'll heal up on their own if they're small, just with some erythromycin ointment as an antibacterial cover, and then monitoring them. If they're larger, they'll need to be surgically closed and punt that to ophthalmology for surgical closure. You're not going to be wanting to suture a conj, especially on an eye that's pretty small. And if that needle goes into the eye, now you've got an open globe. Okay, they'll stain with sodium fluorescein. We'll show you that in the lab as well. We'll talk about Seidel sign there too. Seidel sign is a sign we use. We put a ton of sodium fluorescein dye in the eye, and if there's any sort of globe injury or corneal injury into the globe, the aqueous inside of the anterior chamber will leak out, and it will pool that sodium fluorescein down via gravity, and you'll see that Seidel sign. Call that Seidel positive. Thyroid eye disease. Okay, we've talked about that already. With that scleral show, you can see that superior and inferior sclera there. Okay, that's not normal. Those eyes are bulging out, proptotic or exophthalmos. And it's not just hyperthyroid, although I believe that's the most common. Could be low thyroid as well. And oftentimes these are bilateral conditions. They don't have to be, but oftentimes they are. Okay, with thyroid eye disease, the main thing that I'm concerned about with the eyeballs is them drying out. Okay, leg ophthalmos, or the inability to close those eyes completely, is going to cause them to be dry. So we're going to need to use copious amounts of artificial tears. These patients may also have decreased eye movements because the thyroid eye disease will swell the extraocular muscles and allow them not to move as well. So they may get double vision or the inability to move their eyes completely. Kind of a gradual onset, the lids may be retracted. They're probably going to have other systemic issues going on in addition to their eyes. So hopefully they're getting seen by you all as the primary care docs, and you'll monitor their thyroid. Okay, that's not looking normal. A lot of puffiness there. That also does not look normal. That is a good picture of what is called chemosis, conjunctival swelling. You see, this is actually bulbar conj here. So there's swelling underneath that bulbar conj. Lots of swelling. Not a happy eye there. This is thyroid eye disease underneath the MRI or CT. And you can see where it says MR in those pictures, that is the swollen medial rectus. You can see that compared to the other EOMs, it's quite swollen. See that here on another image. This is straight on, medial recti towards the midline there, also swollen, and then this patient's got a swollen inferior rectus as well. What do we do for these patients? Mostly dry eye therapy. So again, we can tape their lids shut. Patients really hate that though, so we're going to just probably put copious artificial tears on them to treat their eyes, and then we're going to punt them back to y'all to treat the actual thyroid. So once they treat the thyroid, typically the eyes will return to a normal state. All right, flew through that. I'm totally caught back up, which is great. Any questions about that lecture? Wanted to talk briefly about the test. So test is done. It's been done for a while. The way that we write the tests for y'all is based off of mostly the PANCE blueprint. So anything on the PANCE blueprint we'll ask questions about. Most of the questions are going to be vignette style. So a 40-year-old female comes in, blah, blah, blah. 5 answers like your standard tests. There will be first order questions on the test, second order questions on the test. Like first order would be, what is this disease? Second order would be, how do you treat this condition? And without telling you what the disease is. There are some like kind of gimme questions about anatomy, physiology. Hopefully you get those. And the way that I review for the test, you'll notice on Canvas there's a mid-section review and an end-of-section review. I used to just burn through both of those slides in 1 2-hour block, and that was really hard because it's like 300 slides. And I don't think you guys retained a lot of that information anyway, because it's just me droning on for 2 hours nonstop. So the last several iterations, I've just come in with the PANCE blueprint and things that I think are important for y'all to know for my test and for the PANCE exam, and also most importantly, so you're like adequate clinicians with the eyeballs. And that seems to have been working pretty well. So that's all I'm going to do for the last lecture. I'll just have the PANCE blueprint, and we'll run through. I'll ask you, like conjunctivitis is on the upper left, so I'll ask you about the 3 different types of conjunctivitis, how to differentiate between them, what do you treat them with, signs, symptoms, and we'll run through the whole PANCE blueprint like that. And then some other questions that'll be applicable for you to know for testing purposes. That seems to work pretty well. There's pictures on the test. None of the pictures are not from your slides. They're all from your slides. So if you memorize pictures, that may be an easier way to go about taking a test too. I've tried to get rid of a lot of the pictures though, because a lot of times they don't load because the Wi-Fi in here sucks. So most of them are just vignette style. I'm going to teach, when is my next lecture for y'all? Next week sometime? I don't think we're tomorrow.
No, Tuesday.
Sometime. I'll see you guys. I'll teach your next lecture, and then my counterpart, Air Force Lieutenant Colonel Tran, will teach the next 4 lectures, and then I'll be back for the review lecture at the end. So should go pretty well. We're on track now. My next time that I lecture to y'all, I'll do lectures 5, 6, and 7. They're pretty short. They'll be fine. Yes.
For the picture questions, are they going to be more like direct, like what is this, or would it be vignette, like
Still a vignette with the picture supplementing. Most of them you can. Yeah, some of them you can't, which is why again I've tried to get rid of the pictures because they don't load. Yes.
Good. Sorry about yelled at by Jared Goff?
Yeah, thank you. Jordan Groff
Oh.
is an ophthalmologist. Not only is he an ophthalmologist,